Welcome to the Physician Advocacy Institute, PAI's Responding to COVID-19 Telehealth Expansion, presented by Matthew Katz of MCK Health Strategies, part of MCK Consulting, LLC. The Physicians Advocacy Institute, PAI, is a not-for-profit organization that champions fair and transparent government and private payer policies to sustain the profession of medicine for the benefit of patients. For more information about PAI's initiatives, please go to physiciansadvocacyinstitute.org. Any follow-up questions regarding this presentation or PAI can be directed to Kelly Kenny, PAI's CEO, at k2strategiesllc@gmail.com, or to Matthew Katz, myself, a PAI consultant, at mckatz1993@gmail.com. PAI has significant information on its website regarding COVID-19 and physicians' response and information associated with practice resources and activities and events. Please go to PAI's website for more information. Today, we're going to be going over the current landscape of telehealth and telemedicine, some initial federal changes that impacted Medicare and Medicaid, state activities of telehealth and telemedicine, physician practice implementation of telehealth, and an ongoing outlook associated with telehealth now and in the future. There has been an evolution within telehealth over the last few months as a result of the COVID-19 pandemic, and I believe it will have a long-lasting impact on patient care and the healthcare delivery system in this country, particularly with Medicare, Medicaid, and private payers, and how they cover services for patients with regards to physicians and other healthcare professionals. The effectiveness of these new models through telehealth will really determine how far we can go with telemedicine services and the provision of medical care at a distance. PAI prepared this presentation to help providers navigate the new telehealth environment. Prior to the Centers for Medicare and Medicaid Services action on COVID-19, Medicare's coverage of telehealth and telemedicine service was significantly limited to basic services, virtual check-ins, and e-visits. Medicaid, though more broadly covering these services, was still limited, though they did permit care via telephone or other devices that were not provided or allowed under the Medicare program. State laws and regulations varied significantly prior to the COVID-19 pandemic, and private plans also had varying. Before the CMS action, telehealth was covered under Medicare only if a beneficiary was in a designated rural area and received services in a specific setting. Those settings are outlined in this slide. In addition, before CMS action on COVID-19, Medicare fee-for-service access was only furnished by specific providers to established patients. Those are patients that were already seen at a face-to-face encounter by the physician or other healthcare professional. Congress and the administration recognized the need to expand access to telehealth services in response to COVID-19. Medicare has since improved coverage. The Department of Health and Human Services Office of Inspector General has acted to reduce beneficiary costs and also limit impact of existing HIPAA requirements. That's the Health Insurance Portability and Accountability Act, so that there weren't as many barriers to the provision of telehealth services within the Medicare Medicaid program. Also, there were changes to state licensure requirements for Medicare and Medicaid. In March, the Department of Health and Human Services waived those HIPAA penalties and barriers in the Medicare, Medicaid, and other coverage programs under federal agencies. They applied those reductions or those waivers to various providers, as well as various technologies and in various locations to cover Medicare beneficiaries, Medicare and Medicaid beneficiaries. The critical change was the CMS waiver of licensure requirements during the COVID-19 emergency. Providers do not need to be licensed any longer in the state in which they're providing services, so long as they are enrolled in Medicare, means they're a Medicare in-network provider. They possess a valid license to practice in the state that they are enrolled, They furnish in-person or telehealth services to contribute to the relief efforts associated with COVID-19 and are not excluded from practice in any state that they are providing care in or any other state. Within the Medicaid program, states can request a waiver of licensure. Effective March 6, CMS also expanded Medicare fee-for-service telehealth coverage to offices, physician offices, hospitals, beneficiaries across the United States, as well as certain services in a beneficiary's home. Also effective March 6th, CMS provided additional fee-for-service telemedicine coverage flexibility, and they said they will no longer enforce requirements that the provider and the patient have to have an established relationship, and they will not conduct certain audits associated with that relationship. It was March 6th of 2020. March 17th, the Office of the Inspector General for the Department of Health and Human Services also permitted waiver of cost sharing for those telehealth services for patients that are receiving those services. It permitted providers to waive cost sharing if they so chose, and there were certain requirements to providers in waiving those cost sharing aspects of the care that they provided. On March 30th of 2020, CMS waived additional requirements so that they could expand further access to telehealth services within the Medicare program. They expanded the settings to nursing homes and assisted living facilities, as well as additional home care settings. They expanded the number of services provided to 80 that could be done via telehealth, including emergency department visits, home visits, check-ins. And they expanded the technology to include audio or phone-only services, as well as common interactive applications on mobile devices. On March 30th, 2020, CMS also waived additional requirements that specified that telehealth could be done for both new and established patients. So they essentially allowed care to be provided to any Medicare beneficiary for those providers so identified by CMS. They also lifted those limits on frequency of service for certain care settings, and they adjusted some national coverage decisions and local coverage decisions associated with that face-to-face visit requirement and evaluation and assessment. On March 30th, when CMS made those changes, they listed all of the CPT codes, those are the current procedural terminology codes, that they would cover within the confines and context of telehealth and telemedicine. Some of those are listed here on this slide, or can be found on the CMS website associated with that March 30th announcement. On April 23rd, 2020, CMS issued revised guidance that specifically indicated that Medicare Advantage plans, MA plans, may also provide enrollees access to Medicare Part B services, those are generally physician services, via telehealth in any geographic area from a variety of places, including a beneficiary's home. It also permitted MA plans to expand their coverage of telehealth services beyond those approved by CMS in the plan's benefit package. This was important because those plans file annually to CMS their benefit package design, and there was concern that they couldn't do anything that differed or varied from what they had submitted. And on April 23rd, CMS made it clear that they were allowed to vary beyond those as long as it was an expansion of services, not a limitation. In addition to the changes that CMS announced, the CARES Act provided significant funding to enhance rural telehealth services. In fact, $180 million in funding was provided under the CARES Act to allow not-for-profit networks, including providers and hospitals, access to telehealth networks and telehealth resources through grants and other funding to expand access to these services and train physicians and other healthcare professionals and providers. The CARES Act also provided $200 million to the Federal Communications Commission, that's the FCC, to support further expansion of telehealth and telemedicine services, specific to the telecommunications aspect, the networks and delivery methods for the telehealth and telemedicine in rural and urban areas across the United States. The FCC approved its plan for $200 million in telehealth programs that included teaching hospitals, medical schools, community health centers, local health departments, community mental health centers, and skilled nursing facilities. The funds have already some of the funds have already been awarded. To date, more than $7 million have been awarded to institutions, hospitals, medical schools, and community federally qualified health centers to expand telehealth services in those communities. The CARES Act also allowed health savings accounts and high deductible plans or insurers that offered plans that had these HSAs and high deductible plans the ability to cover telehealth services prior to the application of any deductible. In other words, any upfront expense could be allowed under these programs where normally they'd have to come out of the patient's portion, patient's pocket. They were now going to be allowed for the insurer to cover those, and the patient would not have to use their high deductible health savings account or a related account. In addition, the Drug Enforcement Agency, the DEA, and the Substance Abuse and Mental Health Service Administration made some changes to further expand flexibility within telehealth. The DEA made it clear that they would allow mobile devices to be used to assist in the maintenance of detoxification treatment, and that you wouldn't need to separately register a mobile component. In addition, they waived, by evoking public health emergency exception, the requirement that for certain controlled substances, you'd have to have an in-person examination, which means that certain substances now can be provided for those in treatment via telehealth or telemedicine without having first seen the patient. SAMHSA on March 19th issued guidance allowing opioid treatment programs provided through telehealth and telemedicine services, and authorized practitioners to prescribe certain medications without having to have seen the patient face-to-face, and can use telehealth or telephone services in order to provide those services prior to an in-person exam. Here are some resources under Medicare and Medicaid and other federal sources for information associated with the programs, policies, and requirements for Medicare. Medicaid policies, turning to Medicaid. As of September 2019, 51 states, including the District of Columbia, Medicaid programs reimbursed some aspects of telehealth and telemedicine. So Medicaid agencies were already far ahead of federal programs in offering and providing coverage for telemedicine and telehealth services. On March 17th, CMS issued guidance that emphasized that states had a great deal of additional flexibility to cover under Medicaid services for telehealth and telemedicine. That also included where the physician was providing it, where the patient was at the time of care, whether or not there were any ancillary services or costs associated with it. And in fact, CMS indicated that no plan amendment was necessary for a state agency to pay for telehealth services at the same rate as face-to-face services. However, if states wanted to pay more than the face-to-face rate, they would likely have to amend their plan. And they have to ensure that that providers are practicing within the scope of their level of practice and their state practice act. April 23rd, CMS released a toolkit that aimed at further providing flexibility or clarification of the flexibility to Medicaid and children's health programs, further clarifying that patient populations were all eligible for telehealth under Medicaid programs, that coverage and reimbursement was left up to the state, though it allowed them to go up to that Medicare face-to-face reimbursement without having to file additional information or policy waivers. The technology requirements were clarified and expanded, and it highlighted that for pediatric patients, there were further considerations and opportunities to offer telehealth and telemedicine services. Here's some Medicaid resources. States, now moving to states. Virtually all states had laws and regulations on telehealth, though they varied significantly prior to the COVID pandemic. Most states requirements are tied to providers having a granted license within their respective state of practice. That state of practice is generally where the patient resides, not where the provider resides, though some states have specifications tied to both the provider and patient locations when it comes to their laws. Also scope of service requirements, eligibility for providers, which physicians, non-physicians are eligible to provide telehealth or telemedicine services, types of platforms, and which patients could provide those services. In fact, however, since the COVID-19 pandemic, almost 40 states have lessened their telehealth and telemedicine service requirements, including adjusting their provider geographic location requirements, their provider-patient relationship requirements. That's generally seen as the new established patient face-to-face encounter requirements, other patient characteristics, and patient location. 27 states have in fact waived licensure requirements for telehealth altogether, which means you don't need to have a license within that respective state to provide those services. However, the COVID-19 response has increased state variability where there was rather consistency, the standard previously has become very inconsistent across state lines as to what rules and requirements are necessary in order to provide telehealth, telemedicine services, and they're changing every day. Federation of State Medical Board state licensure requirements outline some of these changes and is a good site for information. And here's some additional site for information on changes to state laws associated with telehealth and telemedicine. Let's now turn to the provider's impact and best practices for telehealth. Telehealth can be a valuable tool for patient care during the COVID-19 emergency and pandemic, but I believe only if the practice has a compliance plan and if the practice identifies and uses appropriate billing processes. It is critical that, in fact, the practice outline a compliance plan and use appropriate billing processes and coding practices in order to ensure timely and accurate payment for the services provided. First step for providers and physicians is to establish a compliance plan. Provide medical practice and system leadership review. You need to make sure you have champions within your practice who are going to be highlighting the importance and need for telehealth and telemedicine. You should consult with an attorney, not just the practice's attorney, but an attorney who specializes and understands telehealth and telemedicine, as well as the HIPAA standards and requirements. Even though many have been waived, there are many still that are in effect, and the practice needs to abide by. Consider the use of platforms that are comparable or compatible with the infrastructure that you have in your practice. Don't employ a technology that is too complicated and complex and does not connect with your billing system or practice management software. Also, do not use something that is so basic that you cannot bill or you cannot use it effectively with any other system within your practice. You need to develop policies that are clearly outlined so that your staff as well as patients know how, what, when, why, and where you're providing these services. You need to develop an internal compliance policies that all staff, administrative and clinical, adhere to. And you need to make sure that all administrative and clinical staff are trained on the technology. It is very important that it's not just those that are providing the services that understand the technology, but also the administrative staff that may be assisting in billing and communicating with the patient understand the technology. There will be questions, there will be issues, there will be disruptions, there will be confusion, and it is important that everyone in the practice is interacting with the technology and or interacting with the patient as that training. Step 2 is define the key elements of your plan. You need to reinforce those practices, including informed consent and documentation. Even though you're not seeing that patient in your office at that present encounter, you need to make sure there's informed consent and documentation. The patient has to agree to the service, has to agree to the form of the service. You need to maintain patient privacy and confidentiality and maintain data security the best you can, and And using this new technology in your practice, you have to have the best understanding you can of the technology's privacy, confidentiality, security, so that you can answer any questions that your patients may have. It is incumbent upon the practice to understand those privacy, confidentiality, and security protocols and standards so that you can inform the patients. You need to establish policies that maintain compliance with notification in case of a breach. There has not been many identified breaches with this technology, especially the more higher end telemedicine technology. Though some of the rather basic teleconferencing technology, there has been identified some breaches. So you need to establish practice policies so that you know not only how you're maintaining compliance, but if in fact there is a breach of the technology while you are using it at your practice, how you notify your patients and what the process would be for them to notify you if they feel that there's a breach or a problem associated with the technology. For step 3 for providers, you need to maintain those compliance plans and continually review those plans. You need to, of course, avoid any bad faith conduct or any violation of state laws. You need to make sure that you're using public-facing platforms, avoid using public-facing platforms. Those are crowdsourced type of platforms where multiple people can be on at the same time. Obviously, you don't want to engage in any criminal conduct, and you don't want to misuse any personal health information, patient information during the process. The best thing to do is make sure to consult with your local state medical society and national medical specialty society to understand what your state laws are, what certain procedures can be done, and what CPT codes are best to use in recognizing the services you provide. Also recognize that things are changing constantly from day to day. And so you need to monitor the public statements from your Medicaid agencies, from CMS, and from your respective health insurers that you contract with. You need to establish a plan, an action plan to transition patients if you need to change platforms of technology or when you're bringing them back to the practice to face-to-face encounters. They will become accustomed to this online technology and care modality, and you need to work on a transition for those patients as you start seeing them face. Step 4 for providers is to review the latest CMS information on the codes that are available. I mentioned previously that Medicare had expanded codes to 80 different CPT codes that could be billed and used. It is now 85. Also, I would suggest evaluating the Office of Inspector General flexibility on cost sharing in case you decide to do so, or in case patients ask you questions about the cost sharing waiver requirements. In addition, you need to recognize that in most cases, CPT codes remain unchanged for those visits, and you still need to meet the standards of those visits in order to bill those codes. The Centers for Medicare and Medicaid Services, as well as many private payers, will now require a place of service, a POS code 02, with a modifier GT or 95 for any telemedicine or telehealth service using a CPT code. So it is important to recognize that you need to use those modifiers, and those modifiers may vary by which payer is covering that patient that you're providing that service to. In addition, you need to examine all the payment policies of the commercial insurers as they've constantly changed over the last few months. And I would suggest consulting with the American Medical Association Telehealth Coding Advice Document, which does a good job of outlining some specific coding scenarios. Step 5, I would make sure, again, to make sure that you're using a HIPAA compliant video solution, and also create a business associated agreement with that solution, with that technology, so that you can share certain information with them under the auspices of the HIPAA requirements. Some key questions to ask vendors of telemedicine services and technology that you might employ in your practice. What are the contractual terms? How long will I have to cancel my contract? Will there be any additional costs after the initial payment for use? How quickly can the platform be ready to be used? What devices can physicians and patients use this technology on? Will patients incur any charges for the use of this technology beyond what you might bill them? Commercial insurers and other payers accept a platform? Is there an out-of-office messaging feature? Is there direct messaging? How are patient medical history and records captured, if at all, within the system? These are just some of the basic questions that need to be before employing the technology. The American Medical Association has, again, as I mentioned, some very good examples of COVID-19 telehealth coding and billing. They have them on telehealth visits, virtual check-ins, and remote monitoring. I highly encourage you to go to that document and review that information before you start billing for services. It walks you through the diagnosing of a patient and the patient encounter, as well as whether or not you are referring that patient to other services tied to that telehealth visit. Now I'm going to provide some examples of insurer policies. The Blue Cross Blue Shield companies and the Blue Cross Blue Shield Federal Employee Program indicated that they're waiving cost sharing for COVID-19 treatments, including testing and treatments, as well as inpatient stays. They also indicated that they will reimburse healthcare providers at in-network or Medicare rates for certain services, and those included certain, not all, telehealth and telemedicine services. That varies by Blue Cross Blue Shield plan and by geographic location. United Healthcare indicated that there would be no cost sharing for using live video conferencing for COVID-19 related visits for 90 days. They made that effective March 18th. Aetna indicated that they're also waiving member cost sharing for telehealth visits, including screening and diagnostic tests. That's effective until June 14th. Humana waived member cost sharing for all telehealth services delivered by participating in-network providers and will reimburse those visits at the same rate as the in-office rates effective March 24th. These are some of the large national health insurers I'm giving as examples only. In addition, United Healthcare indicated that they will reimburse for 46 different telehealth services from March 18th to June 18th. While Aetna says that they'll reimburse for 27 health services using telehealth technology. Humana indicates that they will reimburse for 150 telehealth and other virtual services, including check-ins, e-visits, telephone evaluations tied to COVID-19. So there is significant variability by health insurer as to what they're covering, when they're covering it, and how much they're reimbursing, and whether they're reimbursing at the face-to-face rate, at a in-network rate, at a Medicare rate, or some other rate. So it is very important that you check each of your in-network insurers' rates and policies and requirements. There are significant barriers to telehealth and telemedicine. I want to make sure that I'm clear that the issues associated with the cost of technology and what's available in your geographic area. You may be in an area where the internet is limited, if at all. That's the case in a number of rural areas in this country and some urban areas. You need to make sure that there's both patient and provider consent for the use of these services. Payer coverage, and oftentimes there's lower reimbursement issues associated with telemedicine and telehealth. So make sure you know what you're going to get paid before you provide the service. There are some credentialing and privilege and network issues associated with the use of this technology. There's also some medical liability issues. Make sure that your carrier covers you for the provision of these services if you've not provided telemedicine or telehealth. It's incumbent on you to check with your Medicare carrier, medical liability carrier, to ensure that they do cover you for these services. There is licensing variability, as we've mentioned, and of course there's HIPAA privacy, security, and confidentiality issues that continue despite some of the waivers by CMS. Here are some additional resources that you can go to associated with the information I mentioned previously, tied to the AMA and tied to policies that some of the insurers are changing today. Finally, I'd like to go into the outlook of where things are and where they're headed. Recently, NYU Health indicated that they had 1,300 physicians and healthcare professionals sign up new to their platform as of March 2020. 1,300 physicians they had to train, and other healthcare professionals train and present the telehealth and telemedicine technology to. in a month's time. That's significant. Mayor Hawkins, a national company that does studies and reports, indicated that today 48% of physicians are now treating patients using some form of telehealth services. That's up from 18% in 2018. But we have seen more than a doubling of the use of telehealth services over the last 2 years. Another example of the magnitude of change, Blue Cross Blue Shield of Western New York indicated that in March of 2019, they only reimbursed for 135 telehealth visits in that entire month. March 2020, last month, they reimbursed for 20,000 telehealth visits. That is a significant increase in one calendar year. And of course, we have the problem where 35 million Americans lack internet access, and many millions more have limited access. So even though the physician may want to provide the service by telemedicine and telehealth technology, they may not be able to because they may not have access to internet in their practice or at their home, or their patients may not have internet access. Hopefully some of the funding from the FCC that is going to look at telecommunications will improve this, and hopefully some of the other funding available through the CARES Act will greatly expand access to the internet for many millions of Americans who presently do not have access. And then finally, payment from health insurers has generally been yet less than face-to-face care, and most procedures and surgeries we know cannot be provided by telehealth. Access to many services is still limited, and physicians are generally receiving less revenue per patient encounter using telehealth and telemedicine than they were in face-to-face. But it is clear that telehealth and telemedicine technology is greatly expanding and is here to stay for the foreseeable future. Thank you very much, and please visit www.physiciansadvocacyinstitute.org for more information regarding telehealth and telemedicine and other state, local, and national payment policies. Thank you very much and have a very good day.